Welcome to a 1-hour Pallium Project archival podcast of a professional development event. The views presented in this session are those of our expert guests and participants from across Canada. In this podcast, Jackie Peden, an advanced practice nurse in hospice palliative care, interviews Dr. Priscilla Koop of the Faculty of Nursing at the University of Alberta. This session is entitled Family Caregivers, How to Provide Support.
Typically, family caregivers are women in their 60s, although many of them are much older than that. And there are also significant numbers of male caregivers. Typically, caregivers are first-order relatives. They may be spouses or partners. They are often wives and daughters, husbands and sons. Often daughters-in-law get involved in this, and sometimes siblings. It should also be said that although the typical primary family caregiver is a woman, when you look at care networks, males and females are approximately equal in numbers, but the females tend to give more hours of care and broader ranges of care. About half of family caregivers in palliative care have chronic illnesses of their own, and so health concerns are really important, especially given the intensiveness of end-of-life caregiving. When you look at care tasks on their own and the increase in household tasks that come with end-of-life care, people give in the order of 7 or 8 hours of care, but if you take monitoring and emotional support into account, the hours then move up to somewhere in the neighborhood of 13 to 20 hours of care a day. Sleep is often disrupted, and exercise and meal patterns get disrupted as well. So health concerns are really a big issue. And remember that family caregivers at end of life don't get weekends off, they don't get holidays, and often they don't even get good sleep. So we need to really take care, give support to our caregivers. It's important, I think, to recognize that as a society we owe a huge debt to family caregivers. They're doing the care that I gave when I was a young staff nurse, and they're doing that care without the education that I had, and without the training that I had, and without the time off. Although primarily it seems caregivers are happy to provide care, given enough information and support, there are some caregivers who really feel coerced into caregiving and don't feel that they ever get a chance to extricate themselves once they're in it. So we need to be careful about that as well.
Priscilla, can you tell me the difference between, you've talked about Alzheimer's and end-of-life care. Can you tell me a little bit of the differences between family caregivers with those groups of people?
Well, I'm not sure if this is what you're asking, Jackie, but, and I cannot remember the name of the author who wrote about the 3 typical end-of-life scenarios. One of these is that we typically associate with advanced cancer, and that is where the person is relatively well until close to the end of life, and then there's very rapid and significant deterioration, and that's where the caregiving becomes so intensive. Alzheimer's disease and simple frailty have another trajectory, and that one is more where there's a decline over years prior to the death. So caregiving can become intensive for years. Very often institutionalization occurs, and also in Alzheimer's disease the person disappears while the body is often still quite strong. So there are different care needs. The third trajectory is the one you see with organ failure, and there you typically have highs and lows. So, and this is also typical of the hematological cancers. So the person may be pretty okay, and then say the person with advanced heart disease or pulmonary disease catches a cold or the flu, and that's life-threatening for them, and so they may be admitted to an intensive care unit or to a hospital unit. They may die from that event, or they may recover and be relatively well for a while. And so those are the three scenarios. Is that what you wanted to know, or is there something else I can add?
No, that's what I wanted to know. You mentioned family caregiver needs. What are the needs of family caregivers?
The needs of family, both you and Joanne Pollard did some research in your master's research on the needs of family caregivers, and it seems to me that those needs are quite simple and straightforward, but we need to remember what they are. First and foremost, I'd say that family caregivers do not want their own needs to be the focus of nurses, social workers, and others who help them in the home. They want the patient's needs to be paramount. So they do appreciate getting support and help, but they don't want that to happen at the expense of the patient. Now, having said that, their needs are for the information, the skills, the equipment, and supplies that will help them do a good job of providing care. So information is something that comes up again and again in our interviews with caregivers. They want information about the disease process, and they want information about symptoms. They really appreciate it when they're told what to expect down the road. So caregivers have told us over and over again that they really appreciated when the home care nurse, for instance, would say, over the next few weeks you can expect this to start happening, this is what that means, and this is what you can do about it. So they want to know what to expect and how to handle the symptoms. When you're talking about end-of-life care, there are symptoms that otherwise would need urgent treatment, but which in palliative care may be something they just need to put up with or to watch and wait. But there are other things that they need to get help for really fast. And so caregivers want to know the symptoms that are going to occur, and they want to know what they should do about them and the time frame. The last thing that I think is important to mention is caregivers want respite. And we're going to talk later, I think, or maybe we should do it now, I don't know, about what respite means. But a lot of our respite, our notions of respite come from the Alzheimer's literature and the Alzheimer's caregiving system. And for people in advanced cancer, those needs for respite are often different. In health professional terms, respite typically means a service, and that it's often a service that demands that the caregivers and care recipients be physically separated from each other. Now, the caregivers in palliative care have told us, I'm talking about family caregivers now, have told us that they find those respite services, in fact, to increase their stress and anxiety, not to help relieve them. And we found out in the research, and you were involved in this research, Jackie, that to caregivers in palliative care, respite often means relief from being the caregiver and the freedom to be who you are in relation to the dying family member. So it's relief from being the caregiver role, from playing the caregiver role, while being allowed to be the wife or daughter or son or husband. And so that means that respite is a strategy, actually, for caregivers to get a mental break without necessarily the physical break. A mental break from caregiving and the freedom to be who they really are. And caregiving can interfere with being a wife or daughter. So our caregivers, when they achieved respite, often did very simple things, but they did them while they were often in the same room with the care recipient. They would do crossword puzzles, they'd read together, watch TV, or they did yoga or meditated, things like that. Sometimes they wanted to go for a walk, or there was one woman who talked about being with her horses in the barn. But always those activities seemed to be nearby so that they could come and check on the person when they needed to.
You said that the typical services for respite often cause more stress to the family caregiver or increase stress. Why is that?
Well, because it seems to be because the respite services often separate the dying family member from the caregiver. And it's that separation that causes it. And what they want is respite, proximity, the dying family member. The family member is going to be gone in the very near future, and they want to maximize their time with that person.
So providing respite to someone who is closer to death, then is that different than providing respite to a family caregiver who is looking after someone with an Alzheimer's who has a longer trajectory of illness?
Well, it seems that it is, but I think that that's always the question to ask the caregiver. What would work for you? But I think it's really important for professional caregivers to realize that separation that we often insist on with perfectly good intentions, we insist that they take that respite because we want them to be able to take care of themselves and hang in there for the long haul. But in fact, we may not be doing them that much good. So I think the important thing is to ask them what would work for them and try to work around that. It's also important, I think, for us to realize that respite can be achieved while they're right there in the same room.
So are you suggesting that for home care services, for instance, that you could put in respite services to have someone to actually be there to provide care for a certain length of time, but not expect the family caregiver to leave home?
Absolutely. Yeah, absolutely. And while that person is in there giving care, sit down and have a cup of coffee or a cup of tea at the kitchen table.
Can you tell us how else we can provide support to family caregivers?
Absolutely. I think that in general, if you can think of yourself as a colleague with family caregivers in the care of the dying patient, probably what you'll do is just fine. If you keep that role in mind, chances are you're going to do what's needed. But here are some other ideas. As I said earlier, offer information. Try to think about what the family caregivers may need to know down the line and offer that information rather than waiting for caregivers to raise the questions themselves. Many of us have had that experience of being too overwhelmed to know the questions to ask. It takes a lot of energy to think about the questions one should ask, to formulate the questions, to figure out who is the best person to ask those questions of, and then to keep those questions in mind until that person comes around. So I would suggest try to anticipate what the family members and patients will encounter down the road and try to give them that information. Having said that, and having said that family caregivers want a lot of information, I also think it's important to pace that information a little. People can absorb only so much information at one time. Also be prepared to repeat information 2 or 3 times. Anxiety interferes with learning. We do know that. And when you see that caregivers are anxious, tell them. Let them know that they may need to ask that question of you a few more times, and you understand that, and you'll be happy to go over that information with them again if they need to ask it a second or third time. I think it's important also to normalize the information that caregivers need. Let them know that what they need, what they're asking, and what you're telling them these are very normal questions and normal concerns. I think you can say something like, many caregivers wonder about this or that. Is this something that's occurred to you, and would you like information about this? For so many of us, in the kind of work we do, we deal with a lot of information that's quite intimate and sometimes quite embarrassing. But it's routine for us, but we need to remember that it isn't routine for family caregivers. To them, the information is new and simply not part of their everyday life. I think it's also important to interpret to family caregivers what's happening and why. Keep in mind that typically family caregivers have limited anatomy and physiology knowledge, so it's important to kind of listen to what they know and what they need to find out. I remember a man who had coronary artery bypass surgery a couple of months prior to this visit that we made, and he had blood in his urine, and it really scared him. And there was a reason for the blood in his urine. I don't recall what it was, but it was a test or something that he'd had, and that the blood in his urine was quite normal. But he was very worried about it, and really a few questions led us to realize that he thought that one of the stitches had come loose after his coronary artery bypass surgery, and that the blood in his urine meant that he was bleeding from his heart. Now, if you know simple anatomy and physiology, you know that that's not possible, but he didn't know that. So we did a very simple anatomy and physiology lesson, and he was so relieved that he could then hear our explanation for why he had blood in his urine. Until that point, he had told doctors and other people about the blood and his concern, and they just told him not to worry about it. But he did worry, and once he understood the anatomy and physiology, he realized that there was a good reason not to worry, and so he stopped. I think it also is really important in palliative care to deal with common myths about pain management. Pain is not a problem for everybody in end-of-life care, for sure. But when it is, I think it deserves extra attention. Caregivers often, when they give inadequate analgesics, it's often because they have these commonly held myths about the dangers of giving regular narcotics. They worry about addiction, they worry about tolerance, and that, in fact, then when death is near and the pain medication is really needed, it's not going to work, and they'll be having a family member in screaming agony. They also worry that they will inadvertently kill the family member by giving them narcotics. So I think it's worth it to go over those common myths and misconceptions, to be open and gentle, but to raise those issues right from the start and to teach them. I think also it's important to try to establish the kind of relationship with patient and family caregivers that makes it clear to them that they're free to ask anything at all. There are no stupid questions, and the easy questions are sometimes our favorites. So go ahead and ask them, and we will answer them. And I think that the concerns that family caregivers are embarrassed to ask us are the concerns that we then can't deal with. So we need to hear about those. Early in the caregiving experiences, early in the illness trajectory, as early as you can, of course, try to encourage family members to think about and write down the friends, neighbors, family members who might be able to contribute something along the line when things get tougher. There may be people in their social system who can shovel a driveway, sit with the patient when the caregiver goes for a walk, cook a meal, whatever is needed. It's really hard to think about these things when the caregiver is overwhelmed. There are people out there who would like to help but don't want to intrude. And the people who need that help are often too overwhelmed to ask, or they don't want to put anybody on the spot. So I think it's up to the professionals to do whatever we can to connect those two groups of people. Also early in the illness process, encourage photographs and discussions about family history. These can be very helpful later on when things start seeming somewhat bleak, and in bereavement, these are things that the bereaved family caregivers really appreciate. Finally, at some point, I think it's important to let family caregivers know that what they're doing is really important and valuable to their family, the care recipient, to their family as a unit, because they're training the young ones about how to provide care to someone who needs it. But also their caregiving is important to society as a whole. Also warn them that there may come a time when they simply can't continue to offer care, and they may need their family member to be admitted or get in additional support. If you can, tell them to keep you in touch with how they're doing about this and to give you a bit of warning so that you can arrange for further support or an earlier admission to hospice or to hospital. For many caregivers, this final admission can feel like abandonment or giving up, and that can cause tremendous guilt. I think it's important to tell caregivers that every day they have been able to keep their family member at home is a gift. And so what they've done is important.
Providing care at home can be very stressful. Can you give us some tips on how to help the family caregiver cope?
Yes, absolutely. And luckily enough, it's probably, for the most part, what all of us can do to cope. So it's not all that different. When I was a staff nurse at the St. Boniface Palliative Care Unit, we had a sort of a motto that said something like, our job was to help our patients to live until they died. In fact, the CBC did a video of our unit, and it was called Living While Dying. We do whatever we can to help our patients and their family caregivers to really live every day that they have. A key factor, of course, is to manage symptoms while keeping the patient alert. Severe symptoms or drowsiness can really interfere with really living every day. But then the focus, I think, has to be on using each day well. Use the day to talk about what's important, to have a bit of fun and be a little silly, and have a satisfying day. In many ways, this isn't really all that different from for dying people or dying family, if the family caregivers of dying family members, as it is for everybody else. At the end of each day, we should be able to say that we used this day well. And it is during bereavement that it's the memory of those days used well that sustain the survivors.
How do you provide support in a dysfunctional family caregiver situation?
Dealing with dysfunctional families sure can be difficult. So it's really easy to get caught up and to want to side with the family member that you think is the victim, and if the patient and to try to solve the dysfunction. And if the patient and caregiver dyad, or the dysfunctional family, units want to get therapy, by all means, see what you can do to get them the help they need. However, unless you are trained in providing clinical therapy, family therapy, I urge you not to try to fix the relationship on your own. It's so easy to violate the boundaries between the client, the family unit, and yourself. And it can really cause further problems. There are several strategies, though, that you can use in your work with these families, and these strategies are simple but difficult and very important. One is, and this is really important, is to make it clear that you are on each person's side. So you are for everybody. You are for each of them, and this is hard to do. But you need to make that clear, and that will help you stay out of the middle of problems. Second, I think it's important to offer understanding that it's very difficult to give or receive care from someone you don't get along with. It would really be ideal if the caregiver and care recipient could achieve unity, and by all means encourage them to work towards that if they're interested. But the reality is that impending death doesn't turn any of us necessarily into easy to get along with people. So we sometimes get or give care under these less than ideal circumstances. Now, here's one exception, and that is if the dysfunction at any time jeopardizes the safety of the patient or the caregiver, then you have to deal with it, and maybe an early admission to hospital or long-term care institution may be required.
The next question is, what can the caregiver do to help themselves when they are struggling or feeling exhausted?
We had some discussion here at the Pallium office about whether this question referred to professional caregivers or informal caregivers, and so I initially thought that this was for professional caregivers, and many of the strategies can be used for both. I'll try to be clear about what I'm talking about. So here's one strategy that I highly recommend, and that is to keep a simple journal. Now, I know that for professionals, this can seem really daunting. There are some days you can barely crawl home from work. And so I'm going to stress that the word is simple. At the end of the clinical day, write down, answer only one question, and that question is, what did I do well today? And the answer may be really simple. It may be that you persuaded Mrs. S to give her husband his analgesics regularly instead of PRN, or just as needed. It could be that you handled a bad situation better than you ever did in the past. It might be something very profound, and those I don't need to tell you about because you'll remember them. The important thing is to write down a little bit of something every day that you did well, and then to read over your entries over time. I think that's a terrific pick-me-up. I think that for informal caregivers or family caregivers, I think they too can be encouraged to keep a journal. And at the end of each day, write what went well today, or what was a good thing that happened today. And again, keeping those, if you keep it simple, then it's more likely to be done. The second strategy that I recommend, and I know I'm going to start sounding like a Pollyanna, but just bear with me for a while. I think I have friends who do this routinely, and it really works, and I try to remember to do this myself, and that is to give thanks for the good things in your life. And you can do this, and family caregivers can do this also. We all have something that's going well in our lives, and it's good to give thanks for that. And it can be a supportive partner, a child who's delighted to see us at the end of the busy day, our health, a joke you read in the paper or somebody tells you or you hear over the radio, the sight of sun glinting off hoarfrost on the trees, the sight of the northern lights, a car with a really good heater on a cold day, good music to listen to. All of those things are reasons for gratitude. A third one is exercise. And I'm so glad you all have your mute buttons on because I can't hear you moaning and telling me to mind my own business. And I've been there. And as I said, some days you can barely crawl home. And this, again, this strategy can be useful for you as well as family caregivers. Think about the shortest walk you can do on even those really horrible days, or the short exercise video you're willing to watch, or the 2 or 3 yoga stretches you're willing to do every day. Just do them. And while you do that bit of exercise, try to put away the stresses of your work life. And for family caregivers, try to put away the stresses of caregiving. For those moments, just be who you are and be good to yourself and love yourself. And then prepare to deal with your personal and family life or to get right back into it. Another strategy is very similar to one I said before in relation to family caregivers, and that is find out what your friends and your neighbors and family members are willing to do for you on your really bad days, and then ask for what you need. Even young children can bring you a glass of juice and give you a hug and say, "I love you, Mom," or "I love you, Dad." Accept those efforts and say thanks for them. And those strategies are what I'd call really positive ones, and we aren't always in the space for them, so maybe you're going to also have to develop some strategies for really, really bad days. And here's one idea. I have a colleague who writes down the horrible things that someone says or does, and she has a special file, and it has a really foul name that I won't tell you now. And so you may want to keep one of those files, but I suggest that you not do that. I suggest that after you write down the horrible thing that someone said or did to you, that you stop and think about whether there's something you need to do about that. Maybe you need to go to the union or the police or someone's boss and deal with it. If so, do so. Plan to do so. If not, have a ceremony in which you tear that piece of paper up into little tiny pieces and burn it. And while you do that, say to yourself, I am not going to allow this person or this event to darken my life any further. And then do your very, very best to forget about it. I know that's hard. Another thing, when your body leaves work, try to take your mind with you. This isn't always possible, and sometimes we even resolve important issues after work. However, really try to tell the difference between ruminating and problem solving, and try to avoid ruminating. It just destroys your psyche and it takes energy away. Many, many years ago, Elizabeth Kubler-Ross said, when you leave work, go home and soak up some sunshine. And that way, when you go back, you'll have the sunshine to carry with you to your patients. And I think there's wisdom in that. The last strategy I want to talk about is one we often use, and we call it letting off steam or bitching. And I think it's important to pay attention to how we feel after we do that sort of thing. We can call it seeking support from others by discussing our stressful events. And the question always to ask oneself is, do I feel relieved and understood after I have a session like that, or do I feel worse? Letting off steam can be helpful, but it can also simply allow the stress to intrude upon our free time. So try to tell the difference and act accordingly.
The last question is, what do you do when the family caregiver becomes overwhelmed and panic-stricken? You go to make a home care visit, and there the family caregiver is in distress.
Yeah, and I think that's a tough situation, and I think what we need to remember is to keep our stress levels down when that happens. And so I say the first thing you do is breathe. Panic and extreme fear, watching somebody else panicking can interfere with brain function, and so take a few deep breaths and get some oxygen up to your brain, and then think through what needs to be done. I think it's important to try to figure out the kinds of situations that cause caregivers to panic. Often there are patterns for each of us, and so it's important to identify what those patterns are. Is it seeing pain or anxiety in your family member? Is it fear of death and concern that maybe you didn't do enough or you should do more, etc.? Really, it's important to remember that few lay people have been present with someone at the point of death. And TV portrays death in a way that is very anxiety-provoking. So once you figure out what that trigger situation is, walk them through it and say, you know, I'm here to help you, and I'm going to help you figure out what to do when this situation happens again. You may need to write out simple instructions that they can use, because of course the worst situations, the situations you don't know how to handle, typically happen when there's nobody around to help you or 3 o'clock in the morning. And so it's important that caregivers have a few resources to walk them through those stressful situations. I also think that for many people, if they've taken care of themselves, then they may have fewer of those anxiety-provoking situations. It's a lot of problems occur and seem insurmountable when we're exhausted and overwhelmed. And so it's really important that we take care of ourselves so that fewer situations seem that way.
We now have time to open up for questions from the audience.
Hi, it's Tammy McCluskey over in the West Kootenays. I was just reflecting on, as I was taught in working in home care nursing, that you let the patients and the families lead and not necessarily be putting your agenda onto them. And so in looking at anticipating some of those questions, what would you suggest on how to balance those two things?
Thanks for your question, Tammy. Absolutely, I think that you were taught well that the patients and family, it's their home, and you are a guest when you're giving care in their homes. What I suggest you do is offer the information. I think that this point also raises the issue that not everybody wants a lot of information. There are many people who do. So I think it's important to say, here's something that I think is going to be happening in the next few weeks, and is this something you'd like to know more about? And then follow their lead from there. What I'm suggesting, though, is simply to raise the questions so that they don't have to go through that process of thinking them up themselves and keeping them for you.
I just need a little clarification of a couple of the things that you referred to in the early part, Priscilla. You referred to a study that Jackie and someone else had done, and I just wonder if you can either now or email me later the citation for that study.
I'll tell you very quickly and very simply. Jackie Peden and Joanne Pollard were my master's students at the University of Alberta, and both of them looked at family caregiver needs. So if you look up their names in any library database, you'll find the titles for their theses at the University of Alberta, and through interlibrary loan you can get them.
I just wanted to acknowledge what you had said again, specifically in regards to dementia care and individuals with Alzheimer's disease. And certainly there is a difference in the trajectory and the needs of caregivers. There's a lot of concern and I guess lack of understanding as families and providers enter into the end-of-life care, and that people have not been, and I guess that's where education comes in, they've not been informed, I guess, or supported as to what the death for that person will look like and be like. And so we've, at the Society, are trying to certainly work with other colleagues to better support families around end-of-life care because, again, individuals with Alzheimer's disease and other dementias certainly have the need for also quality end-of-life care. And that quite often kind of gets misplaced because the process with the disease process, specifically Alzheimer's disease, can seem so very long.
Yes. Absolutely. I think you're absolutely right. And I think it's important, too, to remember that family caregiving continues even if the person with Alzheimer's is admitted to a long-term care.
Absolutely. It's a different kind of role, but it still continues, and there's misunderstanding around that as well. When there's that transition to care, we used to think that people would be so very relieved, and in fact they weren't, because there was still all these other expectations, and many of them weren't clarified and worked through. And so there was misunderstandings on both sides, from the professional and the provider end and from the family caregiver end. And I guess, again, with our learning, we're getting a better handle on where people are at and really what they need. And that it very much continues to be team care and a team approach.
I agree. I've been involved with some research with Alzheimer's caregivers after they've made the decision to institutionalize their person with Alzheimer's disease. We know that that's a really very stressful decision to make.
Yes.
And yet often they have to then, once they've made that really stressful decision, they have to continue to give care for often up years.
Absolutely.
Before the person is admitted. And so we wanted to know what that was like. And so we're just analyzing those data now, and we'll be...
Excellent.
Okay, so I'm just going to repeat your question because it was hard to hear you. I think you said that humor is really important, it's important to bring some laughter into end-of-life care. Is that correct?
Yes.
And I think you're right. Who was it who said one ought every day to read a good book, hear some fine music, and tell a good joke, or something like that? I'm sure I'm misquoting that, but I think that's part of everyday life, and we need that.
But even in the Alzheimer's, I was speaking with a client yesterday, and just going over some of the things, and he was mentioning it like he shouldn't be saying anything that was anything related to humor, and then when I just started to laugh, and I said, oh, imagine that, and he sort of laughed out loud. And I think that we have to give them permission to be able to laugh at themselves, laugh at some things that are going on, that it doesn't have to be walking into a home because it's end stage and having it be very sedate.
Yeah, it get very grim, can't it?
Yeah, it does.
Yeah, and I think we need to be really sensitive in our humor. Some of us, I'm one of them, has a really black sense of humor sometimes that can be seen as inappropriate, and I think I have to really be careful about that. But I think humor is really, really important. I would agree with you. It lightens our load.
It's Tammy McCluskey again in the Kootenays. I'm just sort of reflecting on system pressures that are on us at end of life and looking at providing respite when there's sort of prescribed criteria and how to work within those, because those can be huge challenges as well, particularly with the information you gave about causing caregiver anxiety that they have to leave and go somewhere else so that they can actually get some respite.
I think probably the information I gave you adds a level of complexity to respite care, but also I would think that at the same time it can be a relief, because what we need to do is to find out what respite means to any given individual. I'm a crossword puzzler. I'm still learning how to meditate. I don't do that well. I love to read. So those are things that I do, and that's very simple. So those are things that I need to be encouraged to take time out to do on a regular basis so that I can get respite for myself. And it's not going to cost the healthcare system a dime, my doing that. I think that other people like to watch TV or do other things. So I think it's a simple matter of finding out what it is that feeds people's souls, to use a certain phrase, or what helps people rejuvenate themselves. What is it people have done in the past to cope with stressful situations, to make their life worth living, and we need to figure out what those are and offer them. And in a sense, it's a bit of a relief to the healthcare system that the respite services, as they now stand, only work for certain people. For many they, in fact, interfere with achieving respite. I guess it just means we need to be a little more creative, but that's what we are. People in palliative care tend to be very creative and resourceful, and I think good problem solvers, and we need to put those skills to work in a really very down-to-earth kind of way.
That was a very informative session on family caregivers, and hopefully answered your needs in the various areas that you are coming from at this time.
This has been a Pallium Project Professional Development Podcast. For more information on the Pallium Project, including written transcripts of this session, please visit www.pallium.ca. PALLIUM.